recognized as I don't think I've ever been recognized as a champion before. Mainly people who don't like me use different names for me, but that was one of the most polite ones. So thank you for that. Again, my name's Eric Jimenez. I'm the Chief Deputy in the State Treasurer's Office. I'm also the chair of the Nevada Office of Minority Health and Equity, their advisory committee. And I believe we're getting more diverse, but I believe I'm arguably the highest ranking person with a disability here in state government. So thank you all for joining us today. I know most of you, it's so good to see Delvon here and my friend Janet Serial as well. But tonight I'm hopeful that we can have a good, productive discussion on some of the barriers that various organizations and people in the disability community face when it comes to access to healthcare, when it comes to access to affordable healthcare particularly. And I know we have some folks with us today from representing the IDD, the Intellectual Developmental Disabilities community, from the deaf and hard of hearing, from the chronic disease realm of things. So with that, I know we have some experts with us today. And I think before we get started, I would love if we could go through each of the folks that are here from these particular communities and talk about some of the challenges that you see every day with the populations that you serve. And to put her on the spot, because I know she loves to be put on the spot, I know Catherine Nielsen, who is appointed by the governor to be the executive director of the Governor's Council for Developmental Disabilities, is here with us today. And I don't know if you'd like to share a few words with us, Catherine.
I actually do. So thank you for putting me on the spot there, Eric. I really appreciate it. Again, everyone, my name is Catherine Nielsen. I am the executive director of the Governor's Council on Developmental Disabilities. And what an honor to be a part of this conversation as well as this population. I myself am a person with a disability. I have family members that are people with disabilities, and boy, does the healthcare topic come up quite a bit in pretty much every realm that we work in and live in. And there are some major barriers that are currently encountered in the state of Nevada, and we really want to make an impact on the change that is coming about as well. And I know we're going to hear all about, Medicaid reimbursement rates and the lack of providers that are available in the state of Nevada. But I'd like to hear from some individuals about some alternatives and some methods to rectify those situations, and how can we make this state much more useful for people with disabilities and those that need healthcare needs. So the council is very excited to support these efforts and be a part of this conversation this evening.
Thank you so much, Catherine. And we also have numerous representatives from the deaf and hard of hearing community here tonight. But in particular, I know we have the executive director on the Commission for the Deaf and Hard of Hearing, Obioma Officer. Obioma, I hope you can see the interpreter, but if you'd like to say a few words, we'd love to have you.
Hi, everyone. I'm just waiting to make sure the interpreter can see me. It's freezing on my screen. Is that just me, the interpreter, or is that freezing for everyone?
It is freezing for all of us.
Maybe we come back to Obioma, or maybe.
Oh, okay. I'm sorry. Okay, the interpreter seems to be able to see me now. So I just wanted to say hello. My name is Obioma. I want to thank you all for having me here and for you all being here as well. I'm really excited to share the different perspectives regarding the deaf and hard of hearing community. Also, I want to say a big thank you to Jewel Eldridge. She is deaf as well, and she represents Nevada Deaf Advocacy. That is Black Deaf Advocacy. Thanks for your patience with the freezing of the video. So she is a representative in that regard, and I want to thank her for being here. Jewel, it's great to have you. Thanks so much, everyone. And back to you.
Thank you. Yeah, Jewel, would you like to say a few words? It looks like you're signing, so.
One moment for the interpreter, please. Hi, everybody. I want to make sure everyone can see me. I'm here on screen signing. Are we good? Can everyone see me okay? Getting a few thumbs up. Good deal. Thank you for having me and thank you for introducing me, Obiama. My name is Jewel. I am a Black Deaf Advocate, president of the Nevada Black Deaf Advocacy. And I have been in this organization for almost 2 years now. I am here to observe and share my experiences, provide a little feedback and perspective with regard to the deaf and hard of hearing. There are others that will speak for themselves too. Some couldn't be here tonight, so I would like to be a representative on their behalf and share also my experiences with you all.
Thank you so much for sharing, Joel. I'm hopeful that we'll have a good conversation. And then lastly,
Yes.
I wanted to introduce Gina Glass, who does tireless efforts for members of the chronic disease community. Ms. Glass, if you'd like to say anything before we kind of really get started.
Hi, everyone. I am Gina Glass with Dream Sickle Kids Foundation. We are the first sickle cell disease organization here in Nevada, and we recently expanded to support all patients and caregivers that are impacted by any of the 7,000 rare diseases that exist in America, affecting about 30 million Americans. Thanks for having me, guys.
Thank you, Ms. Glass. And as I'm kindly reminded, we have one more individual, Lenetra Grady, with First Med Federally Qualified Health Center.
Good evening, everyone. My name is Lenetra, and I am the Chief Medical Officer for First Med Health and Wellness. We recently, well, it's probably been a little over a year, work with closely with the IDD community. We actually go on site to provide care for patients in the IDD community and trying to expand out to more participants in that community. I work for an FQHC, a federally qualified health center. So we serve underserved, underinsured, and uninsured patients. So we really don't turn anyone away. Thank you for having me. I'm excited to be here.
Thank you, everyone, for sharing so far. As we mentioned in the beginning, I think this is a really important session during Minority Health Awareness Month, in that we can meet directly with members of the disability community. And even though we have to still do it over Zoom these days, it's great to see that we can get a little more accessible with the closed captioning and with the ASL interpreters. We've really come a long way over the last 2 years. But hopefully tonight we'll be able to identify some action steps from people in government. You have people in government here today that can help expand healthcare access for all members of the disability community. And we know there are different facets of the community and different challenges that are faced by people depending on what your disability is, or if you have a co-occurring disorder or anything like that. And then figuring out barriers and ways that we can improve that access to improve services. So I'd like to spend a little bit of time, and anyone can feel free to kind of jump in here. I think we'll have a good conversation. But we know that sometimes the level of care that a person is provided or receives sometimes varies based on what kind of disability they have. There's this real dichotomy in, visible disabilities versus invisible disabilities. And I'd love to see if we can kind of go around with the groups and understand what are some of the barriers that people with visible disabilities face, in particular areas of care, and then moving over to some of the more invisible disabilities. So if anyone that's representing any of the physical disabilities or more visible ones, I'd love to hear your thoughts. And I will call on you, Catherine.
Hey, I've already been called on tonight. I'll give somebody else an opportunity and jump on in a little bit. But I think you guys should take this opportunity now to really take advantage of the individuals that are on this call and that can really take into consideration what you have to say and deliver the impact where it needs to be made.
Well, Ms. Serial, do you or Delvon have anything you'd like to add on this particular topic?
Delvon and I were just talking. I think there's just to be clear, there is a lot of ambiguity in terms of people who have intellectual disabilities who quote unquote look normal until they're engaged. And I'd like to talk about physical appearance versus what do you want to call it, Del? Well, we're gonna sit here and talk for a while, but I'd like you to maybe address some of that. How maybe someone can speak to that who is on the call from DD, the person on the call from Governor's Council on DD, on people with intellectual disabilities who don't present as being intellectually disabled because they're quote unquote higher functioning.
You know, Janet, that's a really great topic to bring up, because invisible disabilities, or quote unquote not having what somebody thinks a disability should look like, has created a lot of barriers for individuals with disabilities. We created a video a couple years ago that there's a quote in it that says, well, you don't look like you have autism. And the individual comes back with, well, I don't have autism, but I also didn't know that autism had a look. And so there is a frustration with a lot of individuals about not being taken seriously or not believed that they have a disability and having to prove their status. And that comes along the lines of increasing awareness and increasing advocacy in the community and education to those providers about differing disabilities as well. But we echo that. We hear that a lot, and we hear a lot of the frustration from the community on that too. And that's where self-advocacy comes in to play too.
Hi, this is Lenitra. Are we able to address how we can provide more training for providers so more providers are able to care for patients in the community who have these invisible disabilities? And I agree, patients with autism, we know there are few and far between in Nevada, and we know that there's a long wait list for patients trying to get in just for care because we don't have many providers that are able to care for patients with autism.
Thank you for that. I think that's a really good point. And I think also this is just from my experience, I think this is a particular area of concern for the deaf and hard of hearing community as well, because sometimes, services, ASL services aren't available. And I am really curious in hearing a little bit from the community, are there barriers in mainly communication with providers that you're experiencing now? Can that be improved upon? How? Yeah, and it looks like Jewel, you'd like to start?
Yes, hi, thank you for mentioning that. Yes, I have had experience throughout the years, specifically for a very, very, very long time. services and providers, accessible communication, having interpreters that aren't provided. For example, I went to the doctor's office. Before I went, I called in and requested an interpreter to be provided while I would be there for my appointment. And so sometimes I come in, or they maybe say they're going to refuse an interpreter. They'll say, I can't afford an interpreter. But we, try to inform them the ADA does require to provide an interpreter. The problem I have with that is, again, accessibility. So you might have somebody that has a mental health issue as well, somebody that would need to go to counseling or therapy, and there wouldn't be an interpreter available. So that's a barrier for me and has been over the years. I'm deaf and hard of hearing, the community as well, and people that just aren't aware specifically about interpreting. But now, there's so much technology. I feel like everybody should be aware of what an interpreter is. And that's kind of where I'm at with accessibility and advocacy for other deaf and hard of hearing people. And because some won't speak for themselves. And I know, that they need to know that they have rights. They can ask for an interpreter. And also you might have other, like, for example, with the sheriff department or the police department, you might have a deaf or hard of hearing person, for example, there might be no interpreter, but a police officer might engage them. A lot of times they might say, I'm deaf, or some might say, oh, well, they speak well, they don't need an interpreter. No, I require something that's not just, writing down and lip reading that they would assume would need to occur. So just doing a lot of work to try to improve that communication accessibility for the deaf and hard of hearing. Even deaf blind population, there's not enough services for them as well, or you might have low vision population. So all that is a barrier and has been for quite some time. And here in Las Vegas specifically, I've been here 11 years and I have been fighting and fighting and fighting, to get equity as the same as the hearing people. And it just really is not existent here in Las Vegas, and just trying to establish that and advocate for the others and the other deaf population. And I'm a strong advocate for this here in the community. And I really want everything to be accessible and equitable for all. And it's worth a discussion for sure.
Thank you for that. And I think you bring up a really good point that I'd like to spend a little bit of time on. We know and love the 31 years now of the Americans with Disabilities Act. And while it's great in ensuring that people with disabilities have access, oftentimes people still don't know about it, or seem to think that they can just meet a minimum standard and do not have to go above and beyond to deliver better care. And I would be curious, either from the community side or a provider side, is there any thoughts on how to educate more providers to go above the minimum standard for the ADA, or how to become more inclusive in your practices to serve patients better too, particularly recognizing that disability status is not the only factor in here, right? We all come from diverse backgrounds. We have different, different health outcomes, pre-existing conditions, those sorts of things as well. So if anybody would like to talk about how we could strengthen the ADA specifically with our provider community, that would be useful. Yes, Obioma.
I will just add really quick, this is Joel, just the ADA is very old. The technology, 31 years, like you mentioned, it needs to be updated. It's pretty old. So, a lot of people don't know about it, but it needs to be something like workshops, things provided like that to educate, different trainings that need to exist so that people are aware, and it needs to pop up in different locations. And it needs to be regularly, not just a one-time deal, but it needs to be something that occurs regularly so people are aware of the laws and, be educated so that the services can improve. And it's very important. Oh, I know Obioma wanted to speak as well. Sorry, I got on another camera here because I want to make sure I wasn't frozen. So let me swap this really quick. Oh, let me hold on for the interpreter. I'm going to pin the other one. Okay. Okay, sorry about that. This was a better connection here. So yes, and Jewel is correct with what her comments were saying. She's spot on with her comments. You know, we really need to make improvements. We really need to have workshops and trainings. You know, our providers need to set up things that aren't just more options for people, but more of a training so people are aware of what the ADA laws are. People should be required to learn the ADA. You know, they should learn what it states. It should be something as an annual training. It should be set up as a workshop. We have people that work with deaf and hard of hearing people that work with people with disabilities every day. And people see the disabilities or disabilities that aren't visible, but the provider should be aware of how you can interact with those individuals. And it shouldn't be something that's, you know, oh, I don't want to do that. It should be more of a, you know, let's back that up. And it shouldn't be something that the provider states that they don't want to do. It's the provider don't want. The providers want to be able to learn. They want to be engaged with us. However, it's not required. So they're not aware. They're not aware of what they don't know. They don't know what they don't know. So this is something that's very important as a company, and it should be provided and it should be taught so they're available to have the information so that they know that those are available for deaf and hearing and disability community, and that it's accepted and it's welcomed and they're comfortable to go to that specific appointment.
Thank you. I believe we have Brianna Gill with her hand raised.
Hi, everyone. My name is Bree Gill, and I work for the Nevada State Immunization Program as a data quality coordinator. And I also have hearing loss as well. And so for me, I know a lot of my life experiences have been about self-advocacy because there haven't been times when other people could advocate for me. And so with this, I learned that having some options for a provider to give their patients would be helpful. So for some people, they may need translators. For some people, they just need to see their face. For example, like with COVID right now, and all the doctors' offices are wearing masks and all the doctors are wearing masks. That just makes it really hard to communicate with your provider and to be able to have the ability to see their facial expressions. And sometimes doctors' offices don't have face shields to allow you to be able to read their facial expressions and read their lips as well. So this is also one of the things that I struggled with during the COVID pandemic. And so I wanted to bring this to light.
Thank you. Ms. Neal.
Hello, I'm just wanted to highlight an experience placed in the chat by Paulina Awa. She said, I can never pronounce this right, Takayasu vasculitis, and due to its rarity, similar to all vasculitis, many providers are unaware of the condition or what challenges exist. A specific challenge I faced is even though I'm on the same medication and treatment regimen as some cancer patients, the way many of the resources are written, I am unable to receive resources due to classifications. I feel like invisible disease, especially autoimmune, often gets overlooked on impact of life because it varies so much.
No, I think that's a really good point. I would be curious if anyone else on the call has any comments specific to what we would think of as invisible disabilities or ones that might not be immediately recognizable. You know, what sort of barriers to care, even though those disabilities would still qualify under the Americans with Disabilities Act, are there challenges that you're facing from providers now?
Eric, I do have a comment if you
Sure.
don't mind. Okay, so Catherine, I'm going to say for the record, this is Catherine Nielsen. So I hear you greatly, Paulina, because invisible disabilities really create a label and an assumption based off of a definition or what they can physically see in front of them. And this really creates undue and unjust barriers for individuals in the community that need services or access to healthcare in specific. For a specific example, my husband has severe epilepsy and was in UMC in Las Vegas recently. I have a power of attorney and they tried to separate us, stating that my husband was able to care for himself when he didn't even know his last name. So there is assumptions that are put into place all the time in healthcare settings. And I've seen it increase drastically over the last several years where healthcare has gone downhill. So I really would like to hear from you guys about how do you feel we could educate providers? How can we help break down some of those barriers and eliminate some of those labels and those preconceived beliefs when you have an invisible disability? Especially like somebody who's deaf and doesn't appear on the first hat that they have a disability, or somebody with an autoimmune disease who isn't in a relapse, or somebody with epilepsy who isn't currently having a seizure. And how do we advocate for ourselves and educate those providers in order to break down those barriers? And I'd love to hear from some of you guys about that too.
Janet, would you like to respond, or Delvon?
Yes, Delvon and I are having sidebars here because you're bringing up some very important issues that we've actually been impacted by. I remember when Delvon had a psychotic episode and was placed at West Hills, and they don't have the resources to deal with people with developmental or intellectual disabilities. However, even though I had guardianship, I could not advocate for her. They were not allowing me to assist her in any way. So the intake process was very sullied. It wasn't a good intake because Delvon couldn't answer. First of all, she was in a psychotic state, so she couldn't respond to the questions as she would normally. Secondly, the level of understanding wasn't there. So just as you talk about the need for interpreters, there's a need for staff to be more culturally competent, specifically around different diagnoses, because one diagnosis doesn't necessarily relate to another, especially when they're different, and especially if they're co-occurring disorders like an intellectual disorder and a mental health disorder like schizophrenia or bipolar. For some reason there's a real disconnect, and it still exists. It hasn't been fixed in almost 10 years, huh?
Yeah, 10 years.
10 years now. That disconnect still exists. So we're not even addressing the problem. It's not, I don't even want to say, it's not getting resolved. It's just that every time we go in, we learn better how to deal with it and how to navigate those systems better. But it's not being addressed at all in terms of training and education. And so I love what everyone said earlier about specialized training in working with different disabilities, because again, one size does not fit all for the disabled community either.
She's right about that.
Okay. I want to keep moving, and I think we've identified some barriers specifically on disability status, but I think that there are so many other barriers that people with disabilities face to getting access to care. We know that housing prices are skyrocketing out of control, rents are unsustainable, people are forced to live farther and farther away from transit, and things like that. So I'd be curious from either a transportation side or so other barriers that you're experiencing that really prevent you from getting the best care for either yourself or your loved ones. Tina, do you have something to say?
That was an accident, but actually, Oh, Gina, was it Gina or Tina? We're both.
I was
Go
going
ahead,
to try
Tina.
and sneak something in there, Ms. Glass, before we move away from this topic, because I am here, I'm actively listening, and what I'm hearing as a theme that could be action is in the training realm, in the realm of training. And what I'm wondering is, what would this group think about a movement that tries to incentivize or at least elevate cultural competency and sensitivity training with other forms of, training that professionals must seek out? We talked about how some individuals don't see the value, or that perhaps it's not something that is adopted on a regular basis. It's one and done. You took a course, you checked the box, you moved on. And I'm wondering if this group feels that perhaps a way to elevate this type of training to a level where it becomes incentivized or it becomes much more important. Is that something that we should be thinking about?
I think that.
Obiana, I agree. I think so.
I think that's a great idea to incentivize it. It's actually one of the initiatives that we're working on as an organization, is to educate those providers and the future medical students and public health students in regards to sickle cell disease, which is an invisible illness, and it is an illness that primarily affects people of African descent. So there's a lot of barriers and disparities that are experienced by that group of people. And here in Nevada, with there not being a lot of specialists who have the knowledge or are even willing to accept patients with sickle cell disease, we do want to educate those who do treat patients with sickle cell disease more, and we want to kind of try to reach out to the future medical providers to kind of encourage and maybe come up with a way to incentivize them to actually go into the field of like hematology, oncology, and be able to be willing to accept sickle cell patients to stay here in Nevada and practice rather than go somewhere else to practice medicine. So having incentives would be a good idea for that.
Okay. I'm looking, I see DeMadeline Rice with your hand raised.
Hi there. Thank you so very much. I'm enjoying the conversation. I just have just a bit of input, and that is this. I think that the problem that we have is because we've had ADA with us for so very long, and we do have more of our citizens, of our loved ones in the community. Some are able to function and others not so much. And for those who are in the workplace, I think more needs to be done in the workplace to help employers figure out or have a resource available to them to help them figure out how to actually accommodate those individuals. Because I find that there are times when I'm working with an individual, I understand that the individual has a disability, and there's no reason why they can't do the job, but what more can I do? I don't know if there are more resources available to the employer, or how can we better capitalize on that individual's abilities. That's important to me, because just because they have some sort of disability doesn't mean that they can't contribute to a greater level. That's just my observation.
No, thank you so much for your comments. Carlos Ramirez.
Thank you, Eric. I just wanted to contribute to this discussion in regards to invisible disabilities. Let me turn on my camera so everyone can see me. And it's very dark. I'm sorry if you can't see me. Okay, there we go. And so, and I wanted to add to the conversation because this hits at home personally with my child. I believe my child was misdiagnosed with an invisible disability. He was he was diagnosed with having depression, but I believe he has something else other than that. And so, and this comes down to, you know, better training with providers. And, you know, there's also lack of access, you know, and you know, and I'm talking about children in particular because I have children. And so this is, you know, this is a topic also, a separate topic from this topic, you know, children with disabilities. And so parents like myself, you know, sometimes we have to work long hours. We're not able to take our children to get treatment if they need to. If there's, I'm a single parent, so it's very complicated for me to, you know, to take that step to take my child to get the medical attention that he needs sometimes. And so, you know, even if there's two parents, you know, both parents are working in the household, and it's complicated, you know. So there's also, you know, aside from the access to transportation, there's also access to childcare, and childcare is very, very expensive. And so, you know, these are barriers that we face. And so, you know, we have to focus on these barriers to be able to confront, you know, better medical treatment for children with disabilities. That's all I wanted to say.
Thank you so much for that, Carlos. I think you opened up a whole can of worms there. But I think that's I'm going to get on a soapbox for a little bit, but I think that's an important point, because we know that parents are the best advocates for their children with disabilities, yet sometimes it's almost a full-time job just being your child's advocate, right? And in addition to whether or not maybe you speak English, maybe you don't, maybe you're already working one or two jobs. And I want to get back to the point we were previously on, but I would be curious, either from a provider standpoint or any of the folks on the call, you know, how can the state, how can providers be more supportive of parents who are working with kids with disabilities, you know, recognizing that they can't take off work all the time to go to appointments, that they can't get across town sometime to pick up medications and those sorts of things as well.
This is Lenitra. There are pharmacies out there that will do home delivery, so you don't have to necessarily go to a pharmacy, you know, after hours to, you know, after work hours to try to pick up a prescription. Sometimes you can have your medication home delivered. And again, I'll just go back to saying training and advocating. That is the only way I believe that we are able to educate providers so we are able to take care of certain populations. It really comes down to advocacy and training, period.
Janet?
Okay, Delvon wants to say something about this, and then she wants to talk about transportation. I'm gonna let her tell you about her transportation issues. But I think it's also flexibility. You know, that we have to have more clinics and hours that are maybe in the later in the evening after 5 and hours on the week, on a Saturday, where to be more flexible in when they see the families, because again, all families, especially in Nevada, which is a gaming in communities, they work varied schedules, so they need more flexibility to get their child in there, or create some kind of like, again, I'm seeing more and more of it in the HMO systems. You know, when you have a visit that's 15 minutes, you're not going to cover what's needed for people with disabilities in a 15-minute time frame or 20-minute time frame. Which, if you're under a healthcare maintenance organization, you know, these doctors are like, you know, they get them in and they get them out. And there's not a whole lot of time to converse and really talk about things. And for people with disabilities, especially people with hearing disabilities and speech disabilities, they need more time. And now I'm gonna let Delvon tell you about her transportation issue.
Okay, I had a transportation issue a couple last year, right? And access was not why I would arrive because they weren't coming on time. They were really unreliable for me, and I couldn't ride it anymore. So now I'm not.
So yeah, that was really hard, and Delvon refuses to ride RTC Access. There was a lot of problems with COVID-19, understandably, but what we're seeing is a lot of people are missing their jobs because they can't get to the job. They're losing their jobs because they can't get to work on time, and it's not their own issue. It's an issue of public transport. But there doesn't seem to be any solutions, other than saying, oh, we're sorry, we couldn't pick you up today to get you to your job, or we're sorry we couldn't pick you up to get you to your doctor's appointment. That's the only resources some of these folks have for transportation. So there's no accountability, I guess, Eric, is what I'm saying. There's no accountability for when they can't do the things, and then the people who need the services the most are the ones that suffer.
It's not fair because one of my friends has a disability too.
Yeah, she says she has a peer in her program, her vocational rehab program, that misses work. He misses the program because he doesn't have reliable public transportation.
And that's what happened to me too.
And you too, yes, ma'am.
Thank you for that. I think there are a number of issues here, and I'm in the Capitol right now, and you better believe I'm walking up to the Patient Protection Commission tomorrow, and we're gonna have some conversations about how we can work together to come up, I think, in the next legislative session with solutions that hold, I think, both the provider community accountable, but also some of the other ancillary service providers, whether that's on the transportation side or some of the other connecting pieces as well. But I want to move on a little bit, and I think Catherine brought it up in the beginning of the conversation. We know that this state struggles with its revenue. We know that this state struggles to provide providers with the resources and the rates that they need to deliver the best quality of care that they can. So I'd love to open it up a little bit. And I know this can be a loaded question, but if anyone has any particular comments on Medicaid reimbursement rates, or is the state, adequately evaluating certain services and reimbursing them accordingly, or can we do better, or are there ways for the state to improve on that?
This is Lenitra, and I feel like I'm taking over the conversation, but again, I work for an FQHC, and I'm very sorry to say that I hear a lot of what's going on in a lot of other doctors' offices where you guys are experiencing some of these things. At a FQHC, like I said, we take care of fragile populations. I am not familiar with some of the hardships that you guys are having. We take our time with our patients. We don't rush patients out the door within 20 minutes. We do have flexible hours. We don't have weekend hours, but pre-pandemic, we were open until 7 p.m. every single night because we know there are patients out there who work, who have children. So we did have those hours where our clinic was open and accessible for anyone who needed, to see a provider after 5 p.m. So I'm sorry that you guys experienced those things, but at a FQHC, I really believe that we take our time and our and patience with every patient that walks through our doors. So it's amazing to hear that people refuse interpreters and refuse ASL interpreters. That just floors me, because that is not anything that we experience in any of our clinics.
And Carlos, do you have something to say, or do you just have your hand?
Thank you, Eric. I do have something to follow up with Lenetra's conversation. And so this is great that she's doing that in her clinic, you know. This is a model clinic of what other clinics should be doing, you know, but how do we encourage or entice other clinics to follow their model, you know? And that's just something I was thinking about right now. That's all.
Janet?
Okay, Medicaid is a very big subject in my household. You know, Delvon's very lucky to have my insurance as a retired state employee, because we can't find a Medicaid provider. Delvon has stage 3 kidney disease, and again, finding providers for people with chronic diseases that take Medicaid is almost impossible. Yeah. It is, and then don't let me start with dental, but it's almost impossible. So I can cover, you know, what we do is we go to providers who will take my insurance, and then we pay out of pocket, whatever that out of pocket cost is that we have to pay, because we cannot find Medicaid providers for her chronic disease. Delvon has type 2 diabetes. She's got stage 3 kidney, she's got stage 2 kidney disease, and what is the other chronic disease? Oh, okay. but again, we're having difficulty getting good care and care management teams, because they don't have very many that take Medicaid. They have a lot of providers, but they don't take Medicaid, and that's here in Washoe County.
Right.
And Janet, I would hasten to guess that it's worsened because you are in the north as opposed to being in the population center in the south. Is that a safe statement to make, or am I incorrect?
Say that again, Tina. I'm sorry, I missed what you were saying.
I'm wondering if you can tell me if the circumstance you just described is worsened because you are not in a population center, i.e. in the south, that you are in the north. Is that situation you just described worsened because of that, because of where you are in the state?
I think it may be, I don't know. It does seem to be more specific to the north, because there does seem to be more resources in Southern Nevada. The model though, even in some of our FQACs, there's a limit. I mean, you know, they can take so many Medicaid patients, and then they, you know, they're tapped out. I think the problem is reimbursement still, Tina, to be very honest with you. I hear a lot of providers say that they just, you know, the same headaches they have when I was at Medicaid doing policy and program development over 15 years ago, the same problems they were talking about then they're out now. And what the problem is, there are more people with chronic diseases and more severe chronic diseases now than there were then. So the population is growing in terms of chronic disease. And with the disabled population, a lot of people with disabilities have chronic diseases of sorts, whether that be obesity, heart disease, stroke, they have those comorbidities, so.
Yeah, this is Obiama. I just agree wholeheartedly, 100%. And I think that the South absolutely has more resources. However, with more people, you end up having more people seeing the doctor. And if you've got those chronic illnesses, that means that the providers are overwhelmed with patient care. So that limits their time, their ability to provide services, their acceptance of the Medicaid. I know for me, I don't use Medicaid, but I have talked with a host of different people who say I have tried and they don't have it, or There is no interpreter provided because they have the limitation with the resources, and they want us to bring our own interpreters, our own family members, and the support is not there to have interpreting provided for them. So when they don't have interpreters, there's a limitation there, and so that's an issue. I want to be able to support, people say, I want to support my husband, I want to support my wife. There's not enough interpreters, but it's really unfortunate at the same time with that because we're not getting the service. So yeah, I think to have high quality service, you've got to have more resources and providers, and we just don't have that for the number of patients.
Catherine, thank you, Obioma.
So I weigh on two sides of this. While I understand our Medicaid reimbursement rate is one of the lowest in the country, we also don't have the providers or the services available here as well. So it's a double-edged sword. While we may have the funding available, there just simply isn't people that are willing to work at that rate. And I think that correcting the Medicaid reimbursement rate or reimbursement for services overall, even through private insurance, would really drastically improve providers wanting to come here to provide those services. We see this effect in vocational rehab right now. There's a lot of openings at vocational rehab for counselors, and they have money to provide services through voc rehab, but no counselors to be able to do the work to get those services out. So it is pretty much everywhere we go. It's either there's not enough money or there's not enough people, and Nevada is one of the lowest.
Anyone else on this particular topic? Obioma?
I'm sorry, I would like to add a comment. 1 second, there's some freezing. Is she frozen for you as well? Oh. Okay, that one's better. Let's go with that screen. Sorry about that. Technology. Okay. So unfortunately, with everyone struggling and, we have providers, we have issues with all these different things. In my world, in deaf culture, I have patients and consumers that leave Nevada because, there's no interpreters here anymore. No resources, no access. So the providers and doctors say, well, we're not going to get interpreters, counselors. I mean, what are we supposed to do? So people are leaving their jobs. The interpreters aren't paid enough here. So the interpreters aren't, really willing to work, and they leave, they don't stay in the community. So it's just dwindling down with resources. So for us who do stay and continue to live and have, we need resources, or what do? We leave as well. So it's a very tough situation here in Nevada, and the providers are struggling, we're struggling, and support services are struggling. Yeah. So we're all, I don't know, what do we do?
No, and that's consistently from the deaf community, that is the biggest concern, at least that I've heard for a while. I'd like to advocate, we always need to be training more interpreters, making it more enticing for them, and we need to give interpreters a raise. So thank you, both interpreters on the phone. We really appreciate all that you do here in the state. We need more of you. Are there any other topics we haven't hit on tonight that folks would like to share about, or things that you think we can improve? Obviously, we can't change the world overnight, but this is just the first of many processes of listening and figuring out how we can advocate for change in all the disability communities. But I want to give the floor to anyone if there's something that we haven't covered yet. Yes, go ahead, Obioma.
This is Obiana. I will add 1 second. I think we have to go with the other one here. There we go. Okay. Other thing to consider too would be a lot of time interpreters show up to a job and the provider, or let's say people don't know how to use the interpreter. So maybe they'll say something like maybe they use the interpreter in a wrong way. You know, hey, do you mind holding this for me? And the interpreter is over here using her hands and, you know, they're holding something. They kind of forget that they're just a facilitator of communication. And so I think training on that too would be key. I think that's key to have training for the providers as well. It's important to recognize the support and the support staff and those that have, you know, just really aren't aware of disabilities. So again, it's just important. That's another idea too. Again, like I said, interpreters show up to do their work and they're used inappropriately. You know, then what happens when the deaf person needs an interpreter, you know, and then they don't come back and then the interpreters or the deaf person's stuck.
Okay.
This is Lenitra. I'll just bring up two topics. Just creating more community partnerships with the IDD community, or just so we can build better relationships within the community. I think that's important. And then also increasing awareness so people know how to access certain organizations, or medical offices, so they are getting access to specific services that they're looking for. That's all.
Anyone else?
This is Obiana. I'd like to make another comment to that. I think that, oh, 1 second.
Community health workers that specifically work with the deaf. And well,
Oh. Yeah, as far as contacting us, I think, you know, we need to be contacted for support as well. I mean, bring it on. We're here. Please give us a call and we're here to support you. We want to be able to provide resources. We want to see you. We want to see you thrive. We want to be able to provide development and professionalism, partnership. So feel free. It's important. Pass it on.
Catherine Strain.
Hello, my name is Catherine Strain. I'm with the Nevada State Immunization Program. I just wanted to share some new resources that we're providing. Some of you may have heard of the Pharmacy Partnership Program, where we are partnering long-term care facilities with a pharmacy partner. And this originated with the COVID vaccine, and they can offer a strike team to come into long-term care facilities or to individual homes and vaccinate there. They are able to, we're working on figuring out all the Medicaid, Medi-Cal, all of the different payment options. Of course, the COVID vaccine is free, but we are expanding that program now, and we're calling it Long-Term Care 3.0. And it's a new, we're just starting it this week. There will be a survey that you fill out. It only takes about 10 minutes just to give us your information of where you are and a contact, and we will connect you with either a pharmacy partner or with your local health department. And they have the ability now to offer other vaccines. So routine adult vaccines and routine child vaccines, and they can come to your facility or your house and vaccinate. So, so it's a great opportunity. We think it's going to be very popular. And we will offer this first to those in the greatest need. And so if you have more questions on this, you can contact me. We have an email address that we are monitoring, and it's nvcare@health.nv.gov. And I think I put it in the chat, so maybe they can share that. But again, it's NV Care, so NVCARE at health, HEALTH.NV.gov. And so, and then Brianna is also on the phone, and there is also a program that has been launched by the CDC. That's the schools program. And there is also, I think, a strike team component of that too, for persons that are uncomfortable in a school setting getting their vaccine. So Brianna, I don't know if she's still on the line.
Hello, hi. So for the CDC's School Pharmacy Partnership Program, this is a survey that has been sent out to all the school districts within the state of Nevada. And the school district administrator can submit this survey to request an on-campus vaccine program for students that may need to get vaccines such as the COVID vaccines. And I also believe they have an option to request routine vaccines as well. But this is up to whatever the school district and the pharmacy partner can agree to and support. So that's the school district's pharmacy partnership program. Thank you.
But I would just add that if there are children in a care facility or that are at home that are in need of vaccinations, they can use our long-term care 3.0 program and request vaccines. Thank you.
Thank you. Janet?
Yes, Eric. I would actually I would like to make two suggestions. One that I'm thinking of is maybe, we're doing the community health worker rollouts programs, and I think we need some specialized community health workers that work within the disability communities and work with those communities on how those community health workers can be used to as maybe navigators to help with some of these disconnects that exist. That might be something that we could try to do. I am very disturbed to hear that we are, about some of the things I'm hearing. They're violations of the American Disability Act. They're clear violations in terms of the misuse of interpreters, et And I'm kind of, again, I'm going to put on my enforcement hat for the NAACP.
Right.
Some of these things are again, they're violations. They're not legal. We should be doing something from a accountability standpoint to address some of these things, because they're not only unfortunate and in my opinion immoral, but they're also not they are things that violate the ADA.
Catherine?
Oh, sorry, I had an issue getting unmuted there. So I wanted to make a couple comments on that. First of all, I agree that some of these things are probably borderline illegal. So if you feel like there is something that your rights are being violated, please go speak with NDALC, the Nevada Disability Advocacy and Law Center, and get some guidance from them to determine if what you are experiencing is a violation of your rights, and they can give you some guidance on what to go and do from there. The second thing is, so you mentioned community health workers and somebody who's working in the community to give this sort of guidance. My ears are perking up because in June, we will have a community health worker working in our office that is specific to the disability community to gather input on really the impact of COVID and the public health in the state of Nevada. The federal government is really interested to hear, how did COVID impact your state? How did really public health and healthcare in general impact your state? And really, how can we make this better? And so I'm hopeful that through the use of the individual in our office and the multitude of individuals being hired throughout the state of Nevada, that you guys utilize these opportunities to share that information and let us know what's not right out there. Because we're in an opportunity where we can communicate those needs to make change happen. And you guys are also in a really unique situation that next year is a legislative year. So you will have opportunity to put some BDRs on the map and work with some of your representatives to get those BDRs on the map and see if we can actually make some change. Because we don't know what needs to be changed until you guys, make it blatantly obvious that this needs to happen. So have those conversations and, let us help you facilitate making those changes work.
Thank you. And we're approaching the end of our time. So Tina, I don't know if you want to wrap up or kind of summarize some of the things we heard today.
I have been taking notes like nobody's business, Eric. This has been amazing. So yes, I do have things I'd like to encapsulate and try and make sure that I didn't leave anything off. So yes, public health, give me 1 second. Did anyone want to make a closing remark? Are there any main topics, Eric, that we didn't at least touch upon? I think we touched upon all of them that we intended to, but is there anything anyone else on the call wanted to try and talk about before I wrap things up?
This is Obiana. I would like to, if I could. Let me, I just wanted to, just a last comment. I just wanted to say thank you to everyone. And I would like to thank you for bringing us all together here this evening. Just to have this open discussion on these topics, really hot topics. And, hot topics of need really in our state. So I just wanted to say again, thank you for really opening this discussion up. And Alex, and Tina, and all of you involved, thank you so much. I really appreciate it.
That means the world to me. Thank you so much, Obioma, and to everyone else that has been doing this work, even beyond this call. And just know very, very, very strongly, know in your spirit that this information does not rest here. As we said, we're recording this conversation. We're going to be distributing it out. We're going to be linking it elsewhere. We're going to be utilizing this information. And so I'm going to just take a moment, if that's okay, trying to read a note and summarize what I've heard and things specifically that we can maybe move on, because you've got some really, really some critical people here on this call. We're small but mighty. So this is in no specific order, because I was taking notes kind of crazy. So please forgive me, but tell me if I left anything off. One of the main topics and themes, Eric, that I heard was about training. Professionals, we need to train more professionals so that they can specifically address disabilities, be they visible or invisible. We heard someone speak about resources for those who identify as deaf and or hard of hearing. They're not distributed equitably. And we need to be able to provide those resources in a way that recognizes specialized needs, such as adaptability, the clear masks being made readily available for service delivery staff. I also heard folks talking about just the lack of professionals across various specializations, especially those that deal with chronic disease, things like that. And one way to maybe address that is about incentivizing. Incentivize the requirement for cultural competency. Incentivize that if you do study and become a specialist here, that you don't leave here, that you stay in our state. I also heard, and I made an additional point to that, I added to this, that when recruiting to fill for personnel, to again, elevate the importance of, for example, ASL interpretation. If you're looking for someone who's multilingual to join your staff, to recognize ASL interpretation as a way to address that. Non-traditional resource delivery. We just heard about a lot about the new programs that are going to be coming online about pharmacy deliveries and pharmacy access and immunizations. I think one of the things I heard that was most troubling was Ms. Serial mentioning about Medicaid providers who specialize in chronic disease. That in particular is a very difficult thing to find, as we as a state witness our population is aging and getting more and more people identifying as having illnesses and disabilities. So those two, they need to be aligning and not getting further and further apart. Community health workers trained to work with the disability community. Catherine, kudos to you for bringing somebody on board to address that. And then some other ways to start moving the needle. Again, Eric is the chair for NOMI's advisory committee. Our next meeting is May 10th. Eric is very diligent. We meet before the meeting to develop our agenda, and we're going to be talking about BDR development. And we have a lot to chew on now about BDR development, and July marks the start of BDR development. My office, because of the actions of the last legislative session, will be hiring a public health resource officer soon. And that person is going to be tasked with assessing the gaps in the public health infrastructure. And they're going to be working with their counterpart in the governor's office. So timing, again, these comments are not going to just sit on a shelf. This is going to be passed along to whomever that person is that we hire to start looking into actioning. So before I move on into some other event-based resources that we wanted to share with you, did I leave any other major points out of that summary that we might be able to action? Again, everything was important, but things that are actionable. Did I miss anything? Yes, I see Alex.
Hold on, I have to scroll through my own notes.
Well, no, if you have them in your notes, we don't have to repeat them out loud. But I'm just saying, if there's any of our guests who want to say something that was not captured, you and I'll compare notes for sure, Alex. And to this point, if you did not put your contact information in the chat box, please do, so that we can make sure you're part of our distribution list. We can invite you to the May 10th meeting. As we develop work groups and other activities to action these ideas, we can maybe pull you into that conversation. But just to, I think, do we have a slide with the resources and the events, like Alex, that we can put on the screen? So there's a couple of things that we want to share. There's some of the great work that's going on. Some of it's national, some of it's in the state. There's a deaf, hard of hearing, and speech impaired resource fair, May 28th from 9 to 2. And oh, good, Alex has that. So we've got links if you want to engage, but this is an event for individuals who need resources that come under the telecommunications related assistive technology category. So individuals who are deaf or hard of hearing, or even perhaps someone who is in the in-home service staff profession, IHSS professionals, they would find that resource fair useful. A second event is a webinar called Barriers to Advocacy Experiences Among Rural Parents of Children with Disabilities. So Janet, I thought about you. We can make sure you get that information. It is a $10 cost, and it's free if you're a member of the American Association of Intellectual and Developmental Disabilities. So it's not too cost prohibitive, but if you're a member, it'd be free. And then there's a great training opportunity, everyone. The Nevada Leadership, Education, and Neurodevelopment and Related Disabilities has a training program, and they're currently accepting applications. And what they do is they work to improve the health of infants and children, to your point, Carlos. Children who have autism and other disabilities. And so they're training professionals to address that population. Applications are going on now. And then the last event is really a hold the date event. May 27th to the 28th is going to be our statewide self-advocacy conference. So if we have your email and a link to your email, we'll make sure you get this in a way that makes sense in case you couldn't capture it all on the screen, or if you couldn't, capture it in me just relaying it to you verbally. We'll absolutely share with you the notes. And again, we're taping this, and so with that and with that sharing, I just want to say thank you to those who joined us as subject matter experts, as just allies and advocates. to my amazing facilitator who also serves as my chair, and to just friends and people on this call who I consider friends, just thank you for joining us in this conversation. And I think it was robust. Our goal was to have a robust conversation, Eric, and I think we did.
Great.
That's all I have.
Yeah, I just, awesome presentation. Thank you so much. And thank you everything for your, Jewel, for your contributions about, or excuse me, Edward, for your contribution. Eric, your contributions, and just everything related to the deaf and hard of hearing community. Thank you for that. And also for the speech impaired community. So thank you.
Well, thank you, everyone. I hope you have a wonderful Wednesday. We are almost to Friday. So thank you so much and have a wonderful night.
Thank you, everyone.
Thank you, everyone.
Alex, let's
Bye.
thank
you.
I think it's just us, Alex.
Yes.
So what I'll do, I tried to capture as much as I could, like in my little